Try another one? Okay. Once again, I'll thank Ian for that presentation. Now you can all hear me say that. Ian, I didn't find that boring at all. I think it's fascinating. It's exactly why we invited you to here today. It's provocative. It's challenging. It's very different from the way most of us think about population health and think about business. I appreciate that you laid out a framework at the outset, which I think is one that we can refer to throughout the course of the day today, sort of using the Porter categories and your own interpretation of those. The philanthropic approach, which taps into some motives around expanding markets, around reputation, and perhaps even license to operate, which we didn't really talk about here today yet. The social enterprise or social investing approach, which I think taps into a profit motive, but also a social good motive, market appeal, and so forth. And then the market approach with pay for success, which is a bit different in that it offers a set of payers something that is attractive. I do want to touch on the notion that you concluded with about treating business as something outside or over there when it comes to population health, because I think that is an extremely important theme for us to keep in front of us in the course of the day. I always bristle a bit when someone uses the phrase business and society, as if business is not a social institution, just like education or religious institutions or other things. It is a way we get some things done in our society, but it's not something in and of itself and apart from everything else we do. So I think it's fair that we have expectations of business that are not limited to helping business make money, but that are about looking at what it does and finding ways to encourage and incent business to do what is socially valuable, because it is an institution that's there to be part of our social fabric, not something outside of it. I want to start off with a question for you, and then we'll turn to the roundtable for additional questions, and then our audiences, both here and virtual. The question is, why do investors respond to the approach that you described? Are we in a situation where investors are seeking this kind of investment and risk, or is it because the social sector is pushing it at investors and packaging it in a way that it is somehow attractive to them? And a related question is, you referred to the time horizon. Things 3 to 5 years out are attractive. The presumption is things longer than that are not, yet many population health impacts take much longer to achieve. So I draw from that the implication that pay for success may be better suited for solving certain kinds of problems or for certain interventions than it is for others, and we may need to turn to other approaches in your framework to solve other kinds of problems. But that may be just my reading into it. But if you could respond to that to kick us off.
Sure, thank you. Thank you, Ray, for those questions. So the first question, who's driving this? I think it's coming from three fronts. The first is those investors that you mentioned. There does seem to be an increasing enthusiasm, particularly among the millennials and Gen X folks, to use their money, use their investment portfolio both to make money and also do good. So this is a real trend, and we sort of loosely call it impact investing. Now, I don't think that you can do these deals, whether it's pay for success or otherwise, with investors alone. So you can't invest your way out of a social problem. You need somebody that is capable of solving that social problem and somebody who's willing to pay for solving that social problem. So it really is all three pieces. It's the investor that has an appetite for investments that make money and do good. It is evidence-based social programs that actually solve problems, and it's end payers who are willing to pay for the full value of those problems being solved. And in the case of Pay for Success, that has tended to be public sector agencies, but I can easily imagine health insurance companies or hospital systems willing to pay for improvements to population health as a way to affect their bottom line. So it's all three, all pushing towards the same thing. But I would say I think I have to give credit to the investing community because they really are the ones, I think, with their foot on the gas here saying, we need to fill out this pipeline. I need more investable opportunities. So new enterprises, new nonprofits come online so that I can invest in you and do more good and make money at the same time. So that's a quick answer to your first question. As far as your second question, which is escaping me.
What does it work for and what does it not work for?
So that's a great question, and it's been used in a pretty narrow context thus far. It's been relatively targeted interventions. A behavioral therapy program for recently released prisoners is a way to reduce recidivism. That's fine, and I think we should continue to do those types of projects. But they don't really address the big long-term projects and problems that you referred to, particularly in a health context. So we do need to find ways to take this technology and adapt it to address those long-term problems. Two ways to do that off the top of my head that I think are worth exploring. One is we should probably begin to use pay-for-success contracts for large-scale, neighborhood-scale, comprehensive interventions in more of a master contracting sense. So many of you are probably familiar with the Harlem Children's Zone, for example, in New York. They are a cradle-to-college, neighborhood-based, expensive but effective, large-scale nonprofit. I can imagine a pay-for-success contract between the City of New York and the Harlem Children's Zone that says every year that you can keep the childhood obesity rate in your defined community below the city average and keep crime in your community below the city average and education outcomes above the city average, we will send you $50 million. And on the basis of that financial commitment from the city, the Harlem Children's Zone would then subcontract with an array of nonprofits and others who potentially don't have the capacity to do a pay-for-success project to deliver those outcomes. So that's one way of solving that scale issue. The other is I think we should think about chained pay-for-success projects. So as we know, building a healthy, productive, successful individual begins prenatal, extends into early childhood, adolescence, teenage years, high school, college, job training, et cetera. What if we broke those into their component pieces and had a linked pay-for-success contract that basically allows you to get the time horizon that you need to accomplish the real cost savings to the system, which don't happen until later in adulthood, as a way to pay for all of the requisite investments along that life course. That's a subject that I'm going to be looking into this year as a research project. But I think those are two ways to adapt the technology to address the problems that you mentioned.
Thank you. We're going to go to questions now. Since I'm staring directly into lights, I can't recognize everyone, so I'm going to ask you, as I call you either on the left or the right, to identify yourself, please, before you make your comment or state your question. While we're doing this, I would also ask if our tech support people could make sure that the other microphone is working, because we will need it for the next panel that's coming up immediately after this. So I see Paula.
Hi, good morning. I'm Paula Lance from George Washington University and a member of the Roundtable. I want to talk about Pay for Success a little more. I am the principal investigator on a contract with ASPE, where we're investigating the potential for Pay for Success initiatives in primarily Medicaid and perhaps into Medicare as well. And I think we all understand that the federal government and the Medicaid and Medicare program pays millions of dollars for health care when we could be doing more upstream preventive efforts and save that money. But now that I'm down in the weeds of this, it turns out there are many administrative rules, regulations, and laws that really hamstring these efforts. Many of these are in place to prevent fraud and abuse in these large public programs. But also it turns out that you can't, when you're talking about paying an investor and sharing in savings, in Medicaid, you can't do that for things that Medicaid can't pay for to begin with. So it makes housing, this is a huge challenge. Can't really do it with housing. And then another huge problem is in capitated environments, there can't be shared savings. There's a cap of 105%. So basically, if you're talking about a return of investment, you couldn't pay an investor back more than 5% on their original investment. So on that last issue, I want to ask you if you think, is that enough of an incentive for even some of the, impact investors and socially minded entrepreneurs to get in this sort of game if the cap on the return on their investment from Medicaid, federal Medicaid, would be 5%?
Well, the quick answer to that question is probably not, to be honest. And we have sort of built a regulatory prison for ourselves when we talk about how we use public sector dollars to invest upstream. And we're going to have to think through how we need to adapt some of those rules. Because I've heard that complaint actually quite a bit. And it's not limited to just health. There are a number of public sector agencies and levels of government that would love to invest in upstream activities, but are prohibited by statute from doing so. So part of this is going to require public sector reform, procurement reform.
How do we feel about that?
Well, I think we have to do it carefully. I think, as you mentioned, a lot of these rules are in place for good reasons to prevent fraud. So we need to be thoughtful about it. To address your first question, and as an alternative, I'm very encouraged by some of the coordinated care models that are coming out of the ACA. So in Oregon, for example, which is in our district on the West Coast, they have these new entities called Coordinated Care Organizations, CCOs, which were a creature of the Medicaid waiver that Oregon got as a part of ACA. They're breaking up the state into districts. Each district is run by a CCO. The CCO is actually owned by private sector corporations, health insurance companies for the most part, and hospital systems. And those CCOs are given a global budget to manage their Medicaid populations. I think there's a real opportunity for those quasi-public, quasi-private entities to enter into pay-for-success contracts because it gets you out of that direct public sector contracting box that you were describing. The key is to educate them that this is a relatively low-risk proposition for the CCO. That's the point that I was trying to make with the cartoon of the car, is that the CCO only pays if the Medicaid population they're managing, the health of that population improves and their healthcare costs go down. So I think we can make a compelling argument to these new coordinated care organization structures that this is a great way to invest in upstream determinants that also is free of a lot of the regulatory burden that would otherwise keep government from doing it directly.
Thank you. And I think it's fair to add that there is going to be more and more push for solutions like that from providers of care because they are finding increasingly that they cannot deliver the results that they want to get without the flexibility to be able to deliver social and other related kinds of services as part of the package in public programs or outside of them. Let me turn, I think it's Sani.
Yeah. Sani Magnan from Institute for Clinical Systems Improvement, a member of the Roundtable. Thank you so much, Ian, for your talk. You ended with that we need to reprogram markets to improve population health. And as I sit and think about the two components of Pay for Success, the performance-based contract, the groups you named, I think we're really familiar working with. So government, CMS, insurance companies, hospitals, et cetera, so the payers. But when you name the investors, with banks and foundations and pension funds, they're not groups that we normally interact with. So how do we need to reprogram ourselves to actually work with some different actors here? What do you see, or what would be your recommendations to us?
So that's a great question. And the truth is that all of those investors are motivated by slightly different things. So the first thing that you have to do, honestly, if you're going to approach any of those investors, whether it's a foundation that's making a program-related investment, which is something that comes out of their endowment, which they expect to get back, plus some relatively low rate of return, or a bank that's probably going to want Community Reinvestment Act credit, which is something that we impose on them. It's a requirement that they invest in low-income populations and communities. Or if it's an impact investor who wants a good story, they want to know, is their money actually accomplishing something good beyond just a return on their investment? You need to understand all the factors that are influencing those investors, but the first thing that you need to have in place is an actual investable opportunity. And we tend to talk about investing in the community and investing in social programs and investing in people and kids sort of in a big I way, which is that we should just be supporting these people, the development of these people, and giving them all of the opportunities and access to education that they possibly could need to be successful human beings. That is different from a lowercase I investment, which is something more like your E-Trade account. You're investing in an actual project or an actual business or an actual nonprofit with an expectation of getting your money back plus some rate of return. And it's going to be very hard to get any of those investors to the table unless you have an actual investable opportunity with terms that are favorable to the investor. So I would start there, and then I would dig a little bit deeper and try to get a sense of what are the social motivating factors or what are the regulatory motivating factors in the context of banks that are driving these investors to make an investment in an impact project as opposed to investing in something that is not necessarily impactful. So it's sort of a two-step process, but start with an actual investable opportunity and then build on that from there.
Terry. And I will remind our questioners and our respondents that we have about 10 minutes left here for questions and responses. So please try to be crisp because I see long lines. Terry.
Thank you. Thank you for your presentation. In addition to the foster
Identify
care work,
yourself, please.
Terry Allen, I'm sorry, thank you, Ray, from the Cuyahoga County Health Department in Greater Cleveland and also with the National Association of City and County Health Officials and the Roundtable. Thank you for your presentation. In addition to the foster care work in Cuyahoga County that's happening with Pay for Success, we're now working with the CDC around a how-to manual for Pay for Success around lead poisoning. What we're finding in the process, it's an interesting exercise with Deloitte, is whether or not it's clear from the benefit side it gets fairly diffuse. So your guidance in working through that, understanding whether looking at the juvenile justice system or it could be education, the diffuse nature of those that benefit is affecting some of the conversation. Your insight would be very helpful, and I appreciate the practical way in which you described all this as well. Thank you.
So that is I'm so happy you made that observation about the difficulty of following the money, because there's a lot to unpack there, actually. Because when we think about Pay for Success in its basic form, the idea is that if you make an investment upstream, it will more than pay for itself downstream in terms of reductions in costs. And of course, the key to making it work is identifying who are the beneficiaries of those reductions in costs. Is it government? Is it a health insurance company? Is it a hospital system? And then getting them on board to pay for the interventions that will keep those costs from ever occurring. So that's the virtuous cycle, the circle that makes this all go around. But the problem you identified is a really, really important one, and that is that in many cases, the benefits are diffuse. They benefit not only a particular government agency, but multiple government agencies and levels of government. Maybe it's the county, it's the state, and the federal government. It may benefit a private sector partner, like a health insurance company or a hospital system. So you end up with this very large coalition of end beneficiaries who each have a relatively small stake in making sure this works. It's very difficult to organize them around a Pay for Success project and getting them to contribute their fair share, which is, I think, the problem that you're starting to run into. So I think that is one of many reasons why we should be careful about describing this as primarily a mechanism to save money. I think it's a great line. I think it gets you into the office. It gets your foot in the door of your elected officials and corporate executives. But the truth is that in many cases, success is going to accrue not in bankable, cashable cost savings to government or a private organization, but into efficiency gains. So reducing the prison population in the state of California by 15% would be a wonderful accomplishment in terms of prison overcrowding, which we know is a significant problem here. That is not going to translate into closing any prisons or laying off any guards or eliminating pension obligations. So the cash savings that we think about, the $55,000 per inmate that we pay to incarcerate them, will never actually appear. And if we have sold this as a way to save money, and we get to the end of the contract period and success has occurred, and we look around and there's no extra money, then we're going to have egg on our face. And we're going to disappoint a lot of people, and the mechanism is probably going to be abandoned, and it's going to be the end of this movement. So I try to encourage people to think about the end payment as the sum of all of the criteria that go into a value calculation. So it's not just cost savings. It can be part of it, but it's how much do I value a neighborhood of concentrated poverty that doesn't have lead poisoning? How much do I value a neighborhood that doesn't have a significant portion of low-income children who are having unnecessary asthma emergencies? What's that worth to me? Putting a value on that and making that the basis of the success payment, not necessarily the downstream cost savings that may or may not actually accrue to me or the coalition of folks that you talked about.
Thank you.
Thank you. Thank you, Ian. And I can see we are not going to get to every question. So for those of you who have questions that we don't get to, keep the question. Go ahead and ask it of the next panel, whether they address it or not in their talk. But we don't want to lose any of your contributions and ideas around this. I'll try to get to a couple more before we close. Dave.
Okay, try to be quick. Dave Kindig, University of Wisconsin. We touched on social impact bonds a year or so ago, and I remember asking Ray's question to a panelist. What's in it for these? Why are these investors, going to take perhaps lower rates? And that was the first time that I was aware of these regulatory requirements from the Community Reinvestment Act or
Yes.
whatever on financial institutions. So it's probably a long answer, but the quick picture is, how robust are those? How important are those incentives in this picture? How robust are they? Is that a permanent regulatory framework? Have revisions to that ever been considered?
So the CRA was passed in the late 70s as a direct response to what at the time was a fairly rampant practice of redlining low-income neighborhoods. So banks would take deposits out of low-income neighborhoods and then refuse to lend those deposits back into the same neighborhoods. So Congress decided that was bad public policy and passed the Community Reinvestment Act. That is enforced by the bank regulators, which include the Federal Reserve, the OCC, and the FDIC. It is responsible for an estimated, it's hard to put an actual number on it, but an estimated $60 to $100 billion a year in CRA-motivated bank capital. So presumably these are investments or loans that banks would be less likely to make if they did not have a CRA requirement to make them. The Act has not been significantly updated since it was passed in the 70s. It could benefit from a number of reforms. One of the big challenges that it faces is that this was passed in a time where banks were more or less brick-and-mortar institutions. So there were no ATMs, there was no online banking, there was no banking on your cell phone. So a lot of the emphasis is on the built environment. It's the physical environment in which the banks operate, which significantly encourages banks to invest in things like affordable housing, community facilities, charter school facilities, buildings, real estate development. All of that is important, and it's a significant contributor to upward mobility and solving a lot of the social challenges that we're trying to solve. But it's ultimately insufficient in my estimation. We need to complement that real estate investment with investment in human capital. And that's really where Pay for Success creates a great new investment tool to accomplish those goals. So increasing the number of kindergarten-ready kids. That is not like investing in an affordable housing project. It is an investment in human capital. The CRA is not particularly well equipped to reward investors in human capital projects, and that's something that we're going to have to think through if we expect banks to play a major role in this going forward.
I would also add to that on the institutional side, one of the things that San Francisco Federal Reserve and Kaiser Permanente and others have been discussing is how do you combine the power of the CRA requirements and the community benefit requirements for nonprofit hospitals around common needs, common assessments, and so forth to really build both of those into bear on a particular problem rather than have them operating separately when in fact the same determinants are at play for both. We've got 2 questions left. Let's get the 2 questions on the table and then ask Ian to respond.
Great. Good morning. I'm Claire Braburn with America on Track. From the nonprofit service provider perspective, I love the concept of pay for success. I think we should. It seems pretty intuitive that the government grants that nonprofits receive, they should already be thinking in those terms. It should be pay for success, and a lot of good nonprofits, that is what they're doing, but we know very well that that's not what's always happening with government grants. So to motivate nonprofit service providers that seem to be the middle component here, we've got investors and we've got payers, what are the particularly financial benefits and risks for the nonprofit service providers to enter into this type of contract?
And let's try to get Pam's question as well.
Hi, Pamela Russo from the Robert Wood Johnson Foundation. I've asked this question almost every time I've heard a pay for success, and I don't think I've ever really gotten the answer, which is, so you do the demonstration, the payer pays back the investors, and then what certainty do we have that they'll continue to invest in that same program? That's one. Mm-hmm. The second, very brief, is I've seen some proposed that are comparative. The one you described, Salt Lake City, seemed like it was a prediction of what would happen to those children. It wasn't a comparison like we give this intervention to these folks, but not from those folks, and whether or not investors care about that sort of, controlled trial approach. And the third one is just probably not this discussion. It's just what you think of mission measurement and their social impact prediction stuff.
So thank you for those questions.
What's in it
for
the nonprofit provider?
I'll address the first one quickly. So there is significant risk to nonprofits participating in pay for success projects. Because the reality is if you don't succeed, then you have a scarlet letter that's going to permanently affect your ability to raise any funding whatsoever, even from traditional philanthropic sources. So I would discourage nonprofits that don't have a high degree of confidence in their ability to actually achieve success from participating in these deals. I think, as I mentioned before, the master contracting model, where a big organization with a lot of capacity is able to enter into relatively straightforward contracts with nonprofits, that's a better model for nonprofits that don't have the evidence base, that don't necessarily have the capacity to participate. And I would encourage them to pursue those. But it is a significant risk. I don't want to minimize this. And the beauty of the market solution, of course, from the standpoint of solving a problem, is that capital flows to the successful organizations and away from the unsuccessful ones. And there are going to be winners and losers. And I would just encourage nonprofits to be aware of those risks before entering in to these contracts.
Why don't we take the quick, do investors care about sort of a randomized controlled design, or they just want to see results for the population that was in the particular experiment?
So it's not the investor that's going to care necessarily about whether or not there's an experimental design evaluation or randomized control trial or quasi-experimental, whatever it is. It's the end payer. It's the government agency, it's the health insurance company, it's the hospital system that needs to verify that you have actually delivered what you said you delivered. And in some cases, that could be a relatively straightforward pre-post evaluation. It could be something more in line with what's happening in Utah. But it's really what they're most comfortable with. And they may require a very high bar of proof that you have delivered success. The investor is going to care about that only in the context that it affects the risk profile of the deal. So if it's really hard to accomplish success because of that high level of evaluation, then I'm going to be less inclined as an investor to invest in that project because there's more risk unless you increase the return. So it's not really an investor issue, it's really more of an end payer issue.
All right. Most of you didn't have 30 minutes of brisk physical activity this morning. I hope you just had 60 minutes of brisk mental and intellectual exercise. Ian, thank you very much. So we've kicked off with a very provocative and different kind of discussion. I'm going to bring up the first panel of the day today, which I think you are going to love. It will be moderated by George Isham, the Senior Advisor at Health Partners and Senior Fellow, the Health Partners Institute for Education and Research, and importantly, the co-chair of the Roundtable on Population Health Improvement. So, George, kick it off if the panelists could come up, and I hope we have a microphone solution.
Right.